Okay. My topic today will be recent Western updates in COVID-19 pharmacotherapy. This is up to this day, April 15, and it is an Eastern Afro-Egyptian perspective. I'm Mina Kallini. I'm Assistant Professor at Pharmacology Department, College of Medicine, المنيا University, Senior Consultant for Pharmacology Egyptian Medical Syndicate, and I'm also authors of Kallini's COVID-19 Immunomodulatory Protocol. So what is Kallini's protocol? That we are comparing to the current Western guidelines to treat COVID-19 pharmacotherapy. The name Kallini protocol was published as it is in November 2021 at the highly reputable Inflammopharmacology. And here is a screenshot of this paper. It has been used safely and effectively to both by the traditional as well as the telemedicine to manage mild, moderate, and severe COVID-19 out and hospitalized pediatric, adult, geriatric, and pregnant patients since April 2020, date of my first COVID publication. It is based on novel integrated pathophysiological and immunopharmacological approach to manage COVID-19. Myself, the author, has published 10 COVID-19 articles in journals indexed in PubMed. Many are Q1 and Q2 journals. Other COVID articles published in international medical journal, but not indexed in PubMed. Yet, as well as several COVID preprints that unfortunately is being waited to be peer-reviewed because lack of available, as I believe, other honorable editors and or reviewers for months. I suggest it can end COVID-19. I've suggested this from April 2020. Can end COVID-19 immediately unless for undergoing corruption. It is very economic, and this is the reason that when I address many Western politicians and scientists, including that of UK, Canada, and elsewhere, they ignore it. I have official email receipts. They received it from June 2020, but no official response. Why? Because it is economic. This contradicts huge Western medical, financial stakes with hundreds of billions of dollars, as well as I think racism. And it is not so weird to hear it. I'm proudly African, Eastern, and Egyptian, and I depend on India, Russia, and China to make it through that we can end this pandemic. By the way, this lady, if you can see it just beside me, she has been considered severe COVID-19. She was brought to me almost unconscious. She suffers from chronic hepatitis B. She has multiple risk factors. And in 3 days using Kallini's protocol, she was discharged on her foot. This is the day taken on the 1st of April. And today is the 18th day. She's at home. She's with her family. And I believe this lady would have been murdered in the West or any countries that follows the guidelines saying remdesivir and dexamethasone should treat this lady. No, remdesivir and dexamethasone killed hundreds of thousands of innocents like this lady that should have been with her family smiling and enjoying her life. So Dr. Prasad at Apollo University, at Apollo Hospitals, I really wish you might consider Kallini protocol. It is the only protocol based on several published papers in highly reputable journals explaining why these drugs are effective, unlike the other expensive experimentals that got EUA with corruption, as I'm going to compare right now. But before, let's give a very fast idea how COVID-19 is still undergoing. New variants are coming everywhere to harvest more and more lives thanks to the corruption of USA FDA, as well as other Western agencies all over the world, as I believe and truly suggest. Most COVID-19 drugs, has only FDA EUA, emergency use authorization. But fortunately, some have been revoked even in this month. It is no surprise that updated COVID pharmacotherapy is very crucial for physicians all over the world to be aware of and use it cautiously in a personalized way to best manage our patients. So here is the COVID classification that I'm using. I call it integrated COVID classification. 80% of patients are suffering from mild or moderate symptoms. Yes, just fever, cough, dyspnea, and they usually recover from illness before progressing to the second or third phase. The second phase is called pulmonary phase, and the third is the most severe one. It's called hyperinflammation, or ARDS and other similar classification. 20% go to the second and third phases. They need oxygen supplementation, and severe COVID is usually defined when oxygen saturation is equal to or below 94%, and 5% develop to the cytokine storm or hyperinflammation, which is called critical COVID. This, according to many developing countries, affect from 15 to 25% of hospitalized patients, and this occurs in developing countries. I'm so fortunate, since April 2020 till now, I have encountered many who are classified as severe COVID-19 and no mortality at all. Only mortality if they have already previously taken remdesivir, previously taken dexamethasone. But if Kellini protocol is given from the start, I believe this would abolish a lot of mortalities that could have been prevented. Patient with mild to moderate disease managed as outpatient can progress to to severe disease, usually 7 days after the beginning of symptoms. Yes, this is true. I encountered so much. But there is another US advice which I consider very suspicious. They say SARS-CoV-2 may cause catastrophic illness in any patient, even among those without any risk factors. I'm telling you, no. This has only occurred because they use remdesivir, because they use dexamethasone and what they call severe COVID-19. And I explained in my papers why these drugs and other drugs are not causing any good. They are only causing harm. Should have never received EUA for severe COVID. Dexamethasone might be used for critical, I think yes, but for severe, I don't think no. Remdesivir, I agree with the WHO that it should have never and should never be used for any COVID-19 patient, regardless of the classification. This is WHO official recommendation, and I believe many of you know this. Who are currently considered high-risk groups in the West? Almost everybody. I say it 5 Cs, 5 Ss, 2 Bs, 3 Is, almost everybody. If you see this huge classification, so everybody is high risk. So when you consider that high risk, now you should take Paxlovid. I also have a preprint saying Paxlovid will cause, like remdesivir has also caused, new variants, new fatal variants that we might suffer huge consequences, like also molnupiravir. But fortunately, molnupiravir is considered the least right now to be recommended because it is well known it will cause mutations. So here is the summary of the most American or Western updates with an Egyptian perspective to be explained in just a few slides. For high-risk mild to moderate patient, use Paxlovid. This is the first choice nowadays. And my suggestion, there is an obvious outbalanced risk-benefit ratio when you compare it to Kellini's protocol. But of course, it will help to gain billions of dollars, no matter that as I suggested in a preprint, that many refuse to peer review. It will help evolution of more virulent and fatal variants. So what about, if not feasible, Paxlovid? Then they recommend high-titer convalescent plasma. By the way, just before a few days, they say you might use Paxlovid or sotrovimab, one of the monoclonal antibody. And I know for long that sotrovimab will not do anything better. So currently they just say, no. They revoke the EUA for sotrovimab and just only stick to Paxlovid. And I'm expecting just in few weeks, perhaps they will say, yes, use bebtelovimab, another monoclonal antibody bullshit, as I'm sorry to say it, but it is what I'm strongly saying, to help more and more virulent, variant to evolve. So if not feasible, high-titer convalescent plasma, they recommend, and I agree. It has a place. I think it is very good, and it is economic as well, but they prefer monoclonal antibodies for economic reasons. This is my suggestion. Only if high convalescent plasma, Paxlovid, and sooner bebtelovimab are not available, not working, then they say you might use currently bebtelovimab. Soon it will be first choice, as I know. And molnupiravir, my suggestion, this drug, like remdesivir, should have never received EUA unless Biden administration has invested $1 billion with Merck. So they need it. They need their money back, so they will distribute it to India, to Egypt, to whatever But in USA, as many drugs, no, it will be lost, and I think they will not use it. It is well known, mutagenic, as well as I think Paxlovid also will help creation of more virulent. Here is some clinical pharmacology data about Paxlovid. It inhibits, yes, I think this Paxlovid might be used, but not in mild to moderate. So use it in severe, no, the results are not good. So don't use it at all. Don't use it in mild moderate, that we have a really effective, real life protocols that can end this pandemic unless for the corruption. Ritonavir, for this reason, this Paxlovid has a lot of drug-drug interaction. It is not safe at all to be used for everybody. As Dr. Anils asked, we need some drugs for poor people, for poor patients. And another honorable Indian doctor said, yes, but we might also encourage considering new ideas. There is a protocol used from April 2020 with a lot of papers published to support it, but it is ignored because of Western corruption. And unfortunately, I have no support from my countries that is holding my promotion to associate professor for over 1 year. This is really fantasy. I hope India, Russia, and China might have a look at Kellini's protocol for the best sake of the rising soaring COVID-19 occurring in China as well as elsewhere. Here is some information, if you might go it, and the dose should be reduced in patients with EGFR above 30 and less than 60 milli per minute. It is contraindicated in severely reduced kidney function and contraindicated with numerous drugs. I'm a pharmacologist as well as a physician, so let me assure you that it is not safe at all to be used for all. It might be fatal, and they know it. But if you decide to use it, at least I recommend my fellow physician to use the Liverpool COVID-19 drug interaction. It is free, available, and I used it many times. It is trustful. So my opinion again, evolution of virulent and resistant COVID variant is an existing treatment hazard for Paxlovid, and I highly recommend to reconsider its EUA for mild to moderate COVID. Monoclonal antibody treatment, they were first identified from convalescent plasma, but you know, some studies come saying convalescent plasma are not good. No, low titer convalescent plasma are not good, but high titer are good, or as I do believe, as good as the very highly expensive monoclonal antibodies that makes billions and billions of dollars all over the world with nothing to give an added value if I compare it to Kellini's protocol. And here are some information about it. And for severe and critical COVID, no benefit and potential worse clinical outcome. And this is because of some phenomena called antibody-dependent enhancement, as I suggest in one of my published papers. But I suggest the greatest benefit of and I agree as well, the greatest benefit of monoclonal antibody is mainly in seronegative and immunocompromised patient when given within 7 days of symptoms onset. I also say they are well tolerated. I can't deny it, but high titer plasma are as equal and much more economic than this. Yet also risk of hypersensitivity reaction remain, as well as evolution of resistant variants. That's why I didn't use high titer convalescent plasma or monoclonal antibodies. I don't need it. I don't need them. And here are some examples that made billions of dollars for these antibodies. And the last one is to be revoked, the EUA revoked on April 5 is sotrovimab of GSK, and still, you know, EvoShield. It is, by the way, it is not authorized to be used for treatment. It is only for pre-exposure prophylaxis, and there is a huge difference, by the way. And I think this one will be beptilovimab, the new one that will make billions and billions of dollars out of nothing. For convalescent plasma, let me assure, I agree again, it has a use in immunosuppressive diseases, those who are suffering from immunosuppressive diseases or receiving immunosuppressive drugs. And I suggest also this patient should be the only group that convalescent plasma should be also administered if Kellini protocols didn't work, but it worked for all patients, no exception at all since April 2020. It is much more economic than monoclonal antibodies, even after facilitating screening donors for the high titer to exclude the low titer. However, logistic restriction, I agree, are a big limitation, so Kellini protocol is enough well tolerated. Again, risk hypersensitivity also remains, as well as evolution of resistant variants. Remdesivir, this is the most horrible drug that is heavily used in India, and I think this one has caused the Delta huge rise of this is the Delta variant that was a catastrophe, not only for India, but for the whole world. And they accuse India, no, they should accuse the American remdesivir, the Fauci remdesivir. And a lot of honorable physicians and scientists say this, but we are not here because the NIH bias for this failure, toxic drugs that was not beneficial for Ebola and used it for COVID-19 on bullshit drugs. Again, I must say it for the sake of millions who died because of this and other failure drugs. It is a brew drug. It was the first to receive an EUA in May 2020, and the first to be fully approved months later, just to tease the WHO, I believe. And here is an instruction to use it. I never use it. I will never use it. It is horrible drugs that should have never been used for humans. Toxicity include, among other, cardiac, renal, hepatic, hypokalemia, thrombocytopenia, hemorrhage. It killed lots of patients, telling it is COVID-19. No, it is not COVID-19. It is your remdesivir, Gilead remdesivir, Fauci remdesivir, and NIH remdesivir. It is only highly recommended by the NIH, the ones that caused this global catastrophe for all over the world, thanks to Fauci and his colleagues in the NIH and NIAID. Currently, unfortunately, several honorable guidelines now declassify remdesivir as of its choice for anything. Thus, just using for severe COVID-19, I am saying it is fatal in severe COVID-19. Don't use it. This is my opinion, agreeing with other honorable scientists from all over the world, and I'm very grateful to the WHO, at least for this part, because I heavily disagree with the WHO in lots of other things, including, of course, the vaccines. WHO recommendation after, and not only mRNA and DNA-based vaccines. I don't agree with them in their recommendation, but their recommendation for remdesivir is wonderful. Don't use it for any patient regardless of the disease. Since November 2020, this is an honorable recommendation. I highly recommend my fellow Indian physicians and scientists to revise the evidence using this drug. And molnupiravir is the first oral antiviral to be included. It, by the way, it works through lethal mutagenesis. It is a mutagenic by nature. So this molnupiravir should have never been EUA approved, but in USA, it is considered the least to be recommended. But of course, in India, in Egypt, and other developing countries, it will be like the magic bullet. And it is nothing other than bullshit. Much lower efficacy result compared to other interventions. And the WHO recommend active monitoring of the drug safety. Perhaps it could be carcinogenic, as I published for its relative drug favipiravir in January 2021. Contraindicated for use in patients younger than 18, it is teratogenic. Not only pregnancy test is recommended for female if in doubt, moreover, sexually active male should avoid sexual intercourse or use the reliable contraception for at least 9 days since the start of therapy in order to avoid similar catastrophes. Again, I believe that EUA should have never been issued. An evolution of virulent resistant COVID variants is a potential real hazard. Here is Hippocrates. I think he's weeping right now, wherever he is. COVID is unfortunately not over yet due to several factors that lead to current and potential more virulent variants, which are evolving to evade our natural immunity as well as our medical intervention. Personalized medicine is crucial in management of COVID-19, and a unified prescriptions that occurs in Egypt as well as elsewhere. I think the blatant medical practice, at least, it should be considered a crime as well. And I've once learned that the most shameful act in medicine is to cause harm to a patient suffering from a self-limited disease. And unfortunately, they murdered hundreds of thousands of people that could have been treated with clean protocol since April 2020, using remdesivir, using dexamethasone, using other drugs that cause virulent variants as well as cause mortality, huge mortality. Then just simply accuse COVID-19. This is not the case at all. And let me give you finally one example of COVID malpractice in Egypt regarding this dexamethasone. this is the dose that should be used according to a recovery study that I criticized since day one and managed months later to publish my criticism at Springer Nature Comprehensive Medical Medicine. In Egypt, it is something horrible. They use, for instance, methylprednisone. The dose should be 32 milligrams. In private and governmental Egyptian hospitals, they use methylprednisolone almost 200 milligrams per day. It is almost 10 times over the dose that should have been used. I don't know what else is occurring in other developing countries. The other physician just prescribe it to outpatient without severe. A lot of mortalities in young patients. I think from this severe malpractice, but they heard from the BBC that this is the magic bullet. No, this wasn't the magic bullet. This isn't the magic bullet. And the guidelines are being updated every day, and they will be updated. Sometimes in some hospitals, they give methylprednisolone, 200 milligrams plus dexamethasone. So it was something very, very unfortunate. Killed a lot of young, healthy people saying it is COVID. No, it is not COVID again. It is USA, NIH, and FDA biased recommendation and corrupt guidelines. And here are my references, and you're most welcome to contact me.
Thank you, Dr. Thank you, Dr. Meena.
I appreciate it.
Thank you, Dr. Meena, and you very passionately put forward your personal view. And before welcoming the next panelist, I would like to just say that all the comments and the remarks made on this panel discussion are personal remarks and are not subscribed by the organizers or the other panelists. They should be considered as personal remarks and experiences.
Yes, perspective.
So
yes,
going from Russia, we went to Egypt, and now to Dr. D.K. Gupta, who is the Chairman and Managing Director